The keys for us in terms of neuroprotective intubation is we want to avoid hypotension, we want to avoid hypoxia, and we want to avoid an ICP spike. These are kind of our three goals. But really, these are the two most important goals are the first two, right? And as Peter mentioned before, avoiding hypotension is goal number one, avoiding hypoxia, goal number two, and way below that, avoiding that ICP spike, because a transient ICP spike just hasn't panned out to have a major mortality association for neurologic outcome for these patients. If you have a crashing neuro patient, they're hypoxic, they've aspirated, they are in respiratory arrest, and they're not protecting their airway, you do not have time to finesse and play around with the nuances for a neuroprotective intubation otherwise. In those crashing neuro patients, stick with what you're comfortable with your skill set that you're so good at, your RSI strategies for these patients. If you have a patient who's somewhat more stable and you're doing a semi-urgent intubation, let's say for our patient pre-transport, more because we're anticipating her clinical course might worsen, right? That's where we can get a little bit more nuanced with our neuroprotection and avoiding our ICP spikes. So strategies that can help us with that. Head of the bed up. Even if your patient has trauma associated, you're in spinal precautions, we can still do reverse Trendelenburg. Pre-treating the patient. So the literature describes pre-treatments with fentanyl and lidocaine. Historically, fentanyl 3 to 5 mics per kilo IV, lidocaine 1 milligram per kilogram IV. Those are pretty high doses. I don't know about you. Like I talked about before, I have often layered in a little test dose fentanyl to see how the patient responds with that, and maybe I'm going to layer in some more. Controlling severe hypertension. Most of our experts will say to wait until after the intubation to get really aggressive with hypertension management because these patients often have hemodynamic instability. Once we induce them, we just don't know which direction their blood pressure is going to go. Is it going to take a nosedive because it's just their sympathetic response that was keeping them going, or is it going to go up? Hard for us to say. I typically try and bring that systolic blood pressure closer to the 200 range pre-intubation, but I don't get more aggressive than that until after intubation. Because often the intubation itself and being on the sedation agents with propofol and fentanyl, they're in that nice controlled blood pressure zone. And I don't want to risk hypotension. Drug dose and drug choice, we touched on this a little bit. So whatever you are comfortable with using, whatever you want to use, that's great, right? Not contraindicated to use ketamine, not contraindicated to use etomidate. For blood pressure? Yeah, so you can use hydralazine as part of your blood pressure management. I often will sort of control their blood pressure, initially fentanyl, and then my second dose is labetalol, and then I will then go with hydralazine sort of as my third line. Again, I tend to wait to get really aggressive with the blood pressure control until after intubation, but hydralazine is a very reasonable agent for blood pressure control. IV, you can titrate it, it's nice as an adjunct. What's that, sorry? Oh, hydralazine? That, I think, is pretty weak in terms of evidence, but what I will say, it raises your heart rate. So that's a big reason why we tend to avoid it in things like dissection patients, for example, because we're raising the heart rate. That's going to kind of create a reflex tachycardia after we've given the hydralazine. So that's part of the reason why I tend to give labetalol as my second line and then hydralazine as my third line to augment the labetalol. They've already got some beta blockade on board before I'm giving the hydralazine and potentially driving that heart rate up. Good. And then we talk about this gentle laryngoscopy, so trying to minimize the amount of pressure that we're putting on the vallecula, on the structures. Often I find a little spray of lidocaine topically can be really helpful with these if you have the time, again, if you've got that semi-elective intubation patient.